Hello, everyone. Welcome back. And if this is your first session of the day, welcome to the Preemie Health Talks. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Preemie Health Talks is the first international live series that CPBF is hosting in 2021. These educational sessions are in collaboration with the Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, the Canadian Neonatal Network, the European Foundation for the Care of Newborn Infants, EFCNI, and GLANS, the Global Alliance for Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to empower families of premature babies every step of the way through support and education. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their babies. For these Preemie Health Talks, we brought health experts from around the world and from all over Canada. We've been diving deep into topics affecting preemie health, from breastfeeding to parental mental health during the pandemic, from the importance of kangaroo care to the best practices to protect your baby's skin. If you need closed captioning, you can watch it live from our YouTube channel and enable closed captioning on the screen. I want to thank our sponsors, Medela, Water Wipes, and Prolacta Bioscience for their ongoing support. And please, if you have comments, questions, or want to share your stories, please use the comments on the box below the screen. So we just talked to Kate Robson about Foundations of Wellbeing the NICU. If you missed that session, it is available on our YouTube channel. And next week, all the videos from this week's sessions will be on our website. And right now, we're going to talk about maternal mental health, incorporating trauma-informed care in the NICU. In this talk, Kelly Polci will be asking us to take some time to acknowledge World Maternal Mental Health, which was yesterday. How do we celebrate and carry forward this important cause in a COVID world? Secondly, she'll talk about trauma-informed care and trauma-informed care plans. And I'm bringing Kelly right here to our screen. Kelly, let's unmute you. And Kelly Polci is a Toronto-based psychotherapist in private practice and a social worker practicing at the Hospital for Sick Children. She only recently moved to Sick Kids after 11 years in the Women and Babies program at Sunnybrook Health Science Center. Within their role, she supported hundreds of women and families navigating high-risk pregnancies in the NICU and all the grief and trauma those experiences can bring. Kelly's work includes areas of clinical passion and additional training centered around perinatal bereavement and parental mental health. In addition to her master's, she seeks out training on evidence-based therapeutic modalities such as interpersonal psychotherapy, dialectical behavior therapy, and emotionally focused therapy. Kelly, thank you so much for joining us here today.
Oh, thanks, Fabiana. I'm just so happy that I could be a part of this, and loved everything Kate had to say before me. So
yes, let's continue this conversation because it's such an important topic to talk about, bring awareness about maternal and parental mental health. So I know you have a presentation to share with us. I will let you share your screen. Okay. And for all of you watching us, you can send your comments and your questions to Kelly. We're going to address after her presentation.
Okay, see if I can figure this out. So I'm trying to share.
Okay, you go on share and then share screen, and then there's application window. Your PowerPoint should be there.
Do you see it?
I have a backup here.
Okay.
I always have a backup.
I'm sorry, I'm not sure I'm getting this right. Sorry, I don't.
No, Kelly, I can share my screen, and then you just let me know when to move the slides.
Okay, thank you so much, Fabiana.
Okay, go ahead.
All right, so I'm going to talk, first of all, hi, everybody. It's so fun to see familiar names in the comments section. I'm Kelly, and as Fabiana said, I'm a social worker and psychotherapist. Hi, Lisa. Hi, Kate. Hi, Wendy. So I'm going to firstly talk about World Maternal Mental Health Day and some of the ways in which that's being celebrated this year. And then I'm going to talk about one vision that I have for this wonderful day and wonderful cause of maternal and parental mental health, really, which is to incorporate trauma-informed care and trauma-informed care plans into the NICU. So next slide, Fabiana. So World Maternal Mental Health Day was started in 2015 and 16. So it's a relatively new day, interestingly, and it falls on the first Wednesday in May so as to come close to Mother's Day. This is a voluntary group that was started by a bunch of international partners, including academics, activists, and people with lived experience of perinatal mood and anxiety disorders. And the objectives and goals of this organization are quite simple. They're to raise awareness regarding this topic, increase treatment access, and decrease suffering. They're also interested in looking at influencing policy. So one of the policies that, or a sort of realms of policy that they're interested in looking at is around infanticide and how to reduce some of the criminality that surrounds infanticide, given that it's often coupled with postpartum psychosis. And it's also looking at reducing stigma. Their other messages that they want to further are that no one is immune and that this illness crosses lines in terms of culture, socioeconomic status, sexual orientation, and much more. World Maternal Mental Health Day, if you go to their website, you'll see that they have started a petition and they are looking for the World Health Assembly and the UN World Health Organization to officially recognize World Maternal Mental Health Day. Other messages that the initiative wants to sort of share widely are that there's no health without mental health and that the mother's health is the family's health. And I think we can all agree to that. Next slide, Fabiana. The theme of World Maternal Mental Health Day this year is Let's Invest, a call to action for investment and equity in maternal mental health care. And then you'll see the statistic here that is, again, from their website, around 75% of women suffering do not get diagnosed or do not receive adequate treatment. So a huge element of the World Maternal Mental Health Day initiative is a campaign on social media with the hashtag #MaternalMHMatters. They have a Twitter and Facebook account, and it's really about, broadly sharing the message. I just want to quickly make note of the reference to equity in this year's theme. And I mean, as Kate made note of in her presentation, and if we look specifically at the NICU experience, but also just the experience of parenting in general, this is not the same experience for those of us that are in more privileged social locations. And so while the statistics around perinatal mood and anxiety disorders for women are 1 in 5, the statistic for women of color is 1 in 3. Women will be afflicted with a perinatal mood and anxiety disorder. I'm going to start using the term PMADS that refers to perinatal mood and anxiety disorders, just because that's a wee bit of a mouthful. Next slide. So some events that have been taking place this year for World Maternal Mental Health Day are some virtual symposiums. So as Fabiana mentioned, that was yesterday, was the actual day, but in a lot of locations around the world, you'll note that this is really a week and in some cases even a month of celebration. So just because we're having this conversation a day late, it really doesn't matter in any way. So there was a virtual symposium yesterday, however, that did take place in Canada, and this was put on by the Ludmer Center as well as the Canadian Perinatal Mental Health Collaborative. And if you're a practitioner that's listening in, I would encourage you to look up the Canadian Perinatal Mental Health Collaborative. This is an initiative started by a Simcoe-based practitioner that I know. Her name is Jamie Charlebois, and she's a real champion for this cause, and often has a lot of great resources on the topic. And so this organization is looking for the federal government to create a national strategy on perinatal mental health. And in addition to the Canadian symposium, there were other symposiums all over the world. And I really want to highlight that this topic is really broad-reaching, and that obviously the people that are championing this are doing a really great job, because these symposiums are happening in the UK, in Israel, Puerto Rico, Malta, Indonesia, Turkey, I want to say, was on the list. I mean, really all over the place. So it's wonderful. And then there's an organization that some of you will be familiar with called Postpartum Support International. I'm a big fan of this group and all of the free online support groups that they offer. And they have a campaign called the Climb Out of Darkness campaign. And so these are often community stroller walks. And there's one actually upcoming in the Waterloo region on June 26th. And this is one of the largest, if not the largest, fundraisers for parental mental health in the world. And then another initiative I came across in my research for this presentation was, again, another social media campaign put out by an organization called the Blue Dot Project, and it's hashtag Making Over Motherhood. And this is encouraging mothers to share real and sort of unfiltered experiences of motherhood, so that we can just, again, start normalizing sharing all facets of this experience. Next slide, please. So this slide, really, I'm just asking any practitioners that are listening in now or at a later date to reflect on the topic of World Maternal Mental Health and parental health in general, and reflect on what your organization is doing to champion this cause. I think we all know the statistics around how mental health has been affected by COVID. And I think, some of the organizations I mentioned today, they offer great trainings that practitioners could take. Perhaps you could bring a speaker in, and really there's a great opportunity to be creative in how we acknowledge this in our institutions. Next slide, Fabiana. Okay, well, this is the part of my talk that I was really, if I'm being honest, a bit more excited to talk to you guys about today, and that is the concept of incorporating trauma-informed care in the NICU. So trauma, which again, I mean, Kate really touched on the topic of trauma as well, and I think, broadly, it's defined as an emotional response or reaction to a terrible or distressing event, either that occurred directly to you or that was witnessed. So a trauma event is often typically characterized by a lack of control, vulnerability, helplessness, as well as any issues of communication. And that's certainly a theme that I saw in my work as a social worker in an NICU, that trauma experiences are often amplified if at any time the victim or the traumatized party feels any sense of being dismissed, unheard, or unsupported. So trauma-informed care is an evidence-based and strengths-based approach that recognizes and centralizes the impact of trauma. It prioritizes the physical, psychological, and emotional safety of people who are experiencing the trauma. And it looks for opportunities to rebuild and shift the locus of control back to the traumatized party. So, I mean, when I say the traumatized party, you can safely assume that in this case, I'm referring to an NICU parent. Next slide. So this is a bit busy, but I kind of went through my own mental checklist and tried to reflect on all the different sources of trauma that are specific to NICU. And I won't read this out, but give you each a chance to look at it quickly.
Kelly,
Yes.
you want to mention some out loud would be great because we have closed captioning going on YouTube.
I apologize. Of course. Thanks, Fabiana. Yeah. So, the high risk pregnancy, the transport to the hospital, blood, needles, interventions. I mean, I want to just stop and even mention the hospital in general. Like, some people really strongly dislike or even have a phobia surrounding a hospital environment. Yeah, sights, sounds, sensations. I mean, I think this is going back to what Kate was talking about in her presentation about how sensory and how sensory trauma is. And so I'm just referring to sounds like the sounds of a monitor beeping, the sounds of people talking, interventions taking place, nurses talking. Sights might be the bright lights of an OR, and of course, your baby, and so much more. And often when we're in the midst of trauma, where we might have a lack of orientation to time and space or person. And so even, the most unexpected things might be salient in our mind as we experience a trauma. So, what you'll find in speaking to NICU parents is that sometimes it's a rather seemingly unusual or insignificant type of thing that's really salient to them about what was traumatic. Maybe like something that was posted on a wall or yeah. So here's a long list of sources. I mean, they say, one of the quotes that you often see in the trauma literature is that trauma is in the eye of the beholder. And I think that's absolutely true, in that we each process and appraise life experiences differently. But I also think that as we look at this list, it would be safe to argue that NICU experiences are trauma experiences for many, many people. And this is not a comprehensive list. As I said, this is a list that I just kind of was able to pop off. But I think there's much else you could put on here in terms of what led up to this event, in terms of years of infertility or other losses. Scanxiety is a term I came across in the literature, which I really thought was well said, and that is sort of the anxiety we experience when awaiting results. And then on the side there, you'll see I kind of put what else, and that's referring also to the concept of complex trauma. And that's to say that some of the people that experience NICU might have longstanding or pre-existing trauma experiences. They might have had something, again, that's really commonly discussed in the trauma literature, which is, adverse childhood events. Or ACEs, as they're often called. And so we're looking at the accumulation of multiple trauma experiences. And then we'd be remiss not to mention the additional element of COVID and what it's been like for families to navigate this during COVID. Next slide. Oh, sorry, I did want to add to that last slide, actually, like what, again, sorry, Kate, I keep talking about you. I obviously love you. What Kate was saying in her talk was around the fight, flight, freeze, and fawn. And those are sort of responses to any sense of distress or responses to trauma. And so that's what comes of these sources. And I really loved the reference to the fawning and the sense that sometimes being a parent in the NICU is almost a performative act. You're really trying to navigate becoming a parent in a bit of a fishbowl. And you see the parents sometimes dancing between the different reactions. So they might fawn sometimes and freeze sometimes, or fawn sometimes and fight sometimes. And it's very well evidenced in my experience. Okay. Next slide. So this is a great Instagram account for those of you on Instagram, and it's called @DearNICUMama. I'm not sure if anyone else is familiar with them, but they've got lots of great supportive messaging for an NICU parent who's, currently living through that experience or who has lived through that experience. And this just is some further validation of how traumatic an NICU is. So some quotes that are listed here are that there's nothing that can prepare you for seeing your baby fight or the ache you are left with as you leave them at hospital at night. There's nothing that prepares you for the pride you will feel when they gain another ounce or drink another milk. There's nothing that prepares you to see intensive care written on the wall. And there's a few others listed here, but I'm just really trying to reinforce and deeply validate all the trauma that our families are dealing with. And I think as practitioners, when this is your day-to-day, we sometimes normalize sometimes we don't deeply absorb all the details that these families are navigating and all the trauma, because we're used to seeing stories that have so many traumatic details to them, it becomes a bit normalized. Next slide. So looking at the sources of trauma that I mentioned a couple of slides ago, we will see the residual impacts of this in our NICU population. And so trauma will manifest through behaviors and emotions that we see in the NICU. And it is my hope that we can not pathologize that, and that we can see every behavior as a communication of trauma. And so behaviors, which, I'm not a huge fan of even saying that word, but behaviors like avoidance, panic, hypervigilance, anger, issues with bonding, guilt, and of course the teariness and emotionality, rigidity or control seeking. So like sometimes maybe even an inflexibility. These are all communication of trauma and valid, appropriate responses to such. So the shift when we look at trauma-informed care, and this, interestingly, my friend Oprah recently, she's my friend because I love her, recently talked about this, is that instead of seeing behavior and thinking, what's wrong with you, we look at behavior and say, what happened to you? And it's so often in the NICU, we already have the answer, but we might lose sight of it. So that's why I really want us to just constantly go back to not what's wrong with you, but what happened to you. Next slide. So a huge part of trauma-informed care that we would be providing to NICU families is to manage our own trauma and burnout as practitioners. So as Kate so eloquently put, and I want to reiterate that providers, you we, us, they, you're witnessing all the stuff that I've mentioned over the course of the slides around sources of trauma in the NICU. And so there's this constant cumulative buildup that we experience when we're immersed in that. And so that can lead to burnout or vicarious trauma or compassion fatigue. And so one of our ultimate obligations as practitioners is to try and stay in the place of deep and consistent compassion. And in order to do that, we need to be managing our own self-care and burnout. And so I want to just quickly ask each of you to reflect, regardless of whether you're an NICU practitioner or someone with lived experience in the NICU, to reflect on what are the signs for you when you're burnt out. I'm going to give some examples of signs just to encourage you to brainstorm, and I'm really encouraging you guys to take some time to self-reflect on the topic of what my burnout looks like, and then of course thereafter looking at what can I do about it and what am I doing to address it, because that's really foundational to trauma-informed care, and I'll explain that more in the next slide. But just some examples of what burnout how it might show up for you are, back pain, teariness, overthinking, a lack of productivity, upset stomach, poor sleep, headaches, increased conflict with our spouse, less compassion for patients and families, seeing everything through a negative lens, drinking too much, and the list goes on. Next slide, Fabiana. So a concept that is really big in the trauma literature is that of co-regulation. And so the concept of co-regulation is that as a practitioner, we're obligated to model a calm and regulated state. And that can be done through warm and responsive interactions. And that in and of itself can be really helpful in supporting our families. So it's the idea that there's a feedback loop between my nervous system as a practitioner and the nervous system of the families I'm working with. And so we're co-regulating. Again, so we are working on our own burnout. We are taking the steps necessary to address our own burnout so that we can engage with our families in a calm and regulated way. And this is also a really big concept in the parenting world. I'm not sure if anyone's heard the quote, when dealing with a toddler who's having a huge tantrum, and they talk about, don't join in their chaos, but model your calm. So in summary, caring for yourself as a practitioner is not an aside to trauma-informed care. It is the work of trauma-informed care and allows for successful exchanges with families. Next slide. So now this concept of a trauma-informed care plan. So a trauma-informed care plan is an individualized plan that would be used with each family that you work with at an NICU. So I would propose that this is something that could be created perhaps within a week of admission, and it needs to be done collaboratively with the family. And it's probably a living document that would be edited over time as you move through the different stages of the NICU. And I hope it could be even posted on the wall in each family's room or in the chart as an alternative, so that there's no obligation on the family to provide any handover on this plan and or any obligation on the staff. So I've seen trauma-informed care plans, and that's how I became kind of excited and passionate about the concept of them, used on an antepartum floor in my old gig at Sunnybrook, as well as on a labor and delivery floor. And I've seen them used with great success. And that's why I'm proposing that they could be brought to the NICU. So the 5 concepts of a trauma-informed care plan are safety. So an awareness of that family's safety as well as sources of discomfort. Transparency and trustworthiness. So providing full and accurate information about what's happening and what might happen next. Choice, the need to approach and recognize, the need for an approach that recognizes individual needs and preferences and offers options. Collaboration and mutuality, which acknowledges that healing happens in relationship. I think that really goes back to my co-regulation comment. And encourages us to look for opportunities for shared decision-making. And lastly, empowerment. So recognizing individuals or families' strengths and harnessing those strengths in the NICU. And interwoven throughout any trauma-informed care plan is, again, that concept of co-regulation, as well as lots of active listening, deep compassion, and validation of an emotional response. So that's, again, looking at what Kate was saying and encouraging us to not try to fix negative behaviors or really trying to work through any discomfort we have with any negative or, intense emotional responses, and instead being curious about that and being validating of it. And another theme that you'll see in any trauma-informed care plan is the importance of consistency. So consistency in the care team and a concept in the NICU of primary nursing and a primary care team. I think that is also pivotal, in reducing trauma, but also in having a successful plan. Next slide. So I thought the best way to demonstrate what a trauma-informed care plan is to provide a bit of a case example. So this is a fictional couple, but one that, from my own experiences in a NICU, has a lot of kind of familiar details. So Jane and Mark have struggled for 5 years to get pregnant. Jane has had 2 miscarriages. This pregnancy was high risk. Jane had a subchorionic hemorrhage in first trimester. In second trimester, she had 2 admissions to an antepartum unit with incompetent cervix. She was discharged home each time and encouraged to be on bed rest and on leave from work. On June 15th, at 25 and 5 weeks gestation, Jane began to feel cramping. The couple was rushed to their local hospital, a level 2 facility. Jane delivered the baby at this facility. The couple was told that given baby's gestation, there will be longer-term impacts and developmental challenges that could range from mild to severe. They were also told that their baby would have to be transferred to another hospital located 1.5 hours from their home and has level 3 care, and that this would be happening shortly after birth. So I've just written here, can you imagine being Jane and can you imagine being Mark? And just asking us each to try to get into their shoes. And for some people that are listening in, I'm sure they've been in shoes quite similar to this. So again, this is a familiar type of story for those of us who come from a level 3 environment and even level 2 environments. I mean, you would have seen stories of this nature many times. And I think that I just want to reiterate that sometimes when you're seeing stories like this, they become a bit normalized for you as a practitioner. But if you scan this case example, I think you could probably find at least, I'm going to venture a guess, probably 10 sources of trauma for this family. And so then we could just keep throwing in additional details, pepper this with a few more things like, it's COVID, or this family has other kids at home and no family nearby to support those kids. Or, Jane has a pre-existing history of depression. I mean, often there's also more to these stories than just the actual NICU event. Next slide. So this is a bit of a busy slide. I apologize, but I'll read it to everybody. So as it relates to safety, here's an example of what a trauma-informed care plan might indicate. So Jane doesn't like to learn things when she gets to the hospital. She calls for a morning update, and then she lets the team know what her plans will be in terms of coming to the hospital that day. She asks that if anything changes between the two, she is contacted. She asks that we contact her cell phone as the first point of contact. Jane is more introverted, and she is still processing multiple losses and lots of grief. When she cries, which is often, she prefers to have space. She does not want to talk about it right away. A statement like, "I'm here if you want to talk," will be sufficient. Mark likes procedures to be explained in great detail before they happen. Transparency and trustworthiness. Jane and Mark will try to come to rounds, but also appreciate a daily bedside update from the NP and the RN. Again, Mark tends to prefer more details and will often need to know the reasoning behind things that happen day to day in the NICU, even seemingly small things. He will become agitated if he feels that those questions are not being answered. Mark would like head ultrasound results, even insignificant ones, as soon as we have them. He does not wish for us to wait until the couple is next visiting the hospital. Mark also likes people to introduce themselves and their role. He gets overwhelmed by the large team. Choice. Jane and Mark try to come every day at the same time, but they can't always do so. They both like to KC a lot. It helps when they have choice regarding the timing of that kangaroo care. Jane wants to participate in care, but is also sometimes nervous. She likes to be offered the opportunities, but also does not wish to be pressured. If you tell Jane she cannot participate in a certain care task, it helps for her to know why. Mark likes to present on rounds. Collaboration and mutuality. Jane and Mark are the experts of their own needs as well as their baby's temperament. Jane thinks that the baby loves music, prefers to be on his left side when sleeping, and loves his soother. Jane hates eye exams. She wants Mark to be present for them and for any and all available comfort strategies to be employed. When immunizations come up, Jane asks that an eye exam and an immunization not happen back to back. Empowerment. Mark loves to joke. He does well with nurses that like to socialize. Jane is an avid cyclist, yogi, and reader. Learning about her strengths reminds her that she has strengths that she can tap into. Furthermore, given her love of reading, Jane will often benefit if we give written information about key NICU topics. So I hope that in showing this example, and I mean, it's just one example, you can start to maybe reflect on what your trauma and informed care plan might have looked like when you were in the NICU, and or what some of the families you work with as practitioners might have put in their plan. And so, as I said, again, this is developed collaboratively with the family. And it might be hard for the family to self-identify some of this stuff, especially if we're looking at stuff that they can't really anticipate because it hasn't ever happened to them before. So it would be helpful for us to have a bit of a list of examples of different things that might come up so that we could populate this document. And again, it would be a living document that could change over time. But I hope that in showing this example, you can see how the locus of control shifts more to the family, and that it also is almost like a narrative for the family. And so they're sharing their story, their strengths, their likes, their dislikes, their triggers, and their preferences. And it really sort of centers that and gives them some of that power back. Next slide. So that's really kind of brings me to the end of my presentation, and sort of just some conclusion points that I wanted to make is that I want us as practitioners to look at all behavior. Again, I'm struggling with the word behavior, but looking at all actions, I guess, in the NICU as through the lens of trauma. If you're a practitioner, prioritizing your own self-care and self-reflection is the most important piece of trauma-informed work. And that allows you to be regulated, warm, and responsive. And lastly, I'm asking that we consider the concept of trauma-informed care plans in our NICUs as an opportunity to shift control and improve communication with our families so as to minimize their distress. And that's all.
Thank you so much for this presentation. Oh my God, I learned so much about trauma-informed care. To be honest with you, I didn't know much about it. I really appreciate all that you share with us. And I think I share the same thoughts with Lisa. She said, I love this. And I want to also thank Yvette from joining us from Portugal. Somebody from Mexico is here. So thank you so much, all of you, for joining us here today. Kelly, very important conversation, especially this week, on Maternal Mental Health Day yesterday, as you put all the events that are happening to raise awareness and the stigma and really support families and get them to the resources that they need. So my question to you is, this trauma-informed care plan, is something that every family in the NICU should receive, or some specific families who you already know there is some history there, or families will have a long NICU stay?
Yeah, I think it's a good question. I mean, I think with anything like this, you have to reflect on the feasibility. I think always we want to capture as many people as we can, but realistically in practice, that's not always possible. I know that at Sunnybrook, where I was working, there was a lot of focus on micro-prems and having a family meeting within the first week of admission with any of our micro-preemies families. And so perhaps that's a realistic way to try rolling it out and then broaden it from there. Alternatively, you could sort of assess and evaluate how the family is coping and adjusting initially. But again, I think so much of what, people are experiencing is sometimes hidden. So maybe the way a family is truly coping and adapting is not always visible to us as practitioners. So there might be a danger in only offering that to those families that sort of overtly, expressively appear to be not coping well.
So when you have that plan, is that plan shared with the NICU staff? Because obviously we have different nurses, not all the time your primary nurse is there, or sometimes you don't have a primary nurse. Is this shared with the team?
Yeah, I think that's the vision, is that, I've seen scenarios where, things just we can't expect things to be handed over one shift to the next. I think certain clinical details usually are, in that handover, but like the broad strokes overview of this family and their story and their preferences, those things sometimes get dropped with handovers. And so I think the vision is that this would be created and perhaps it's posted in the room as a highlight to the staff involved. I can think of an example of a family, where, perhaps it's that mom doesn't like to get the calls from the hospital. They just trigger a lot of anxiety when the phone rings, and that she really can't process that medical information. And so she requests that the call initially go to her husband, just as an example. And so that's the type of detail that's then posted, and then it can't get lost, and we can't run into an issue where, and I don't want to be negative on a poor fellow in the middle of the night, but like a fellow in the middle of the night won't know that detail and will call mom, right? So the idea would be to post it.
Okay, we have a question here from Petula. Who is in the NICU would create the trauma care plan?
Yeah, that's a great question. I mean, again, it's a collaborative process. I could certainly see it being something that falls within the realm of the social work role. Alternatively, I see it happening in a family meeting environment with several members of the care team present. And so working through this with multiple team members in the room. It really depends on your team and sort of the culture and the functioning of each team. But those are a couple ideas.
Okay, so you mentioned trigger before. Do they ever go away? Because obviously, NICU parents are traumatized, and you go home, and then you have to go back to the hospital, and the smell of the soap or the beeps, the alarms, it can be triggered like years later. So do they ever go away, and how do you deal with that?
Yeah, I think I like the smell of the soap. I think that's an interesting example, but I think probably yes and no. I mean, it really depends on your journey and your process towards healing. And so I don't think there's a right or wrong in terms of whether, the impact is lifelong, that there's, you're sort of going back to the scene of the crime, if you will, if you want to put it in the terms of other trauma, right? Like, this is where you were in a very distressing sort of moment in your life. And so in terms of how to manage that, I think some of the stuff that Kate mentioned around deep breathing strategies, grounding strategies. So there's a lot of sensory elements to the grounding. What she talked about, like an essential oil or a little perfume bottle or an object that you bring with you that just sort of centers you and grounds you in those moments. I mean, there's a lot out there on the topic of grounding when we feel some of that distress response or trauma stuff resurfacing.
So I think my next question is, how much of those triggers is expected or considered, I hate that word, normal? And when do you feel that families really need to look for help? Or how can we access if you really need help that is not a momentarily trigger, but this is something that is really affecting my everyday life?
Yeah, I would look at, I think it's a great question to bring to a trusted care provider, such as a family doctor or, whether it's an obstetrician or someone else that you trust. If you're not sure, right, like it would never hurt to run it by another person. But I would say, if we look at symptoms like nightmares or flashbacks that are pretty persistent or recurring quite frequently, I think you might want to take a closer look at stuff like that. And I think any sort of obsessive types of behaviors or compulsive types of behaviors that are, again, causing you and impacting you in terms of your ability to function in your day-to-day life, then you would probably want to take a look at that. So, a compulsion like, I sanitize my hands before I touch the doorknob, and then after I touch the doorknob, and, before I enter the room and after I enter the room. And it's starting to really impact your capacity to function in your life.
And families can access their local resources. Always there's a family, ask the family doctor or social worker in the hospital. There are options out there for families, right?
Absolutely. Absolutely. And, even if you are functioning in your day-to-day life, but you still want to, process this stuff further, or, continue the conversation and just, again, have a sounding board on that. Like there's so much good therapy support out there, like your COVID cares stuff through the foundation, it being a great example.
Yeah, I'm just sharing the website because we do have a free therapy sessions for families in the NICU and up to a year post-discharge. It's not a crisis line, but it's with psychologists and psychotherapists specialized in perinatal mental health that can really help to find more resources in the community. But Kelly, my last question to you, can we find joy in trauma?
Can we find joy in trauma? I mean, I think absolutely yes, right? I mean, I think you can simultaneously, have two, and I often say to families too, because we talked earlier about how sometimes practitioners have a discomfort with negative emotion, but sometimes also it's families and mothers themselves, fathers themselves that are just like have a discomfort because they're like, I feel such a darkness or a grief, but like my baby's here. And like, I don't want my baby to absorb this energy. There's a lot of sort of that superstition of like, I can't bring this negative energy into the room, into the unit. I can't really share this. I have to project a sort of a positive, hopeful thing because, and so I want people to feel like they can have both things happening simultaneously. I can at once feel a deep grief and fear, and also celebrate, the little micro moments, the small wins, the good days. I think those things can be happening simultaneously.
Absolutely. And I experienced that because I did lose one twin. It was a stillbirth and I had Gabriel in the ICU for 5 months. So I was experiencing the grief of losing one twin and while celebrating my surviving twin in the ICU, even with all the hiccups that he had, the setbacks during his NICU journey. So yeah, I carried both feelings at the same time. And obviously one day I had to segment them and deal with one at a time to really heal my own grief. So I think we all have different ways of coping and strategies, but I always believe talking to someone, to a professional, is always a great way to really help you to make sense of what is happening or what happened, right?
Yeah, absolutely. Yeah, it's it's certainly a passion for me, and that's why I love supporting this population in my private practice as a psychotherapist. And I just always want to have supports out there for this population. So I really, I think, keep talking and keep reaching out.
Absolutely. Kelly, I'm sharing your website if somebody wants to be in touch with you. But I really want to thank you for sharing your expertise, your knowledge with us today. And I'm very grateful for all the work that you do for an NICU family. So thank you.
Thanks, Fabiana. My great pleasure to be here. Take care.
And for all of you watching us from home or from the hospital on our YouTube channel or Facebook, thank you so much for joining us here today. And if you miss a talk from this week or for the first few talks, the first talk of the day today, you can watch the recordings on our YouTube channel. And next week, they'll be available on our website. I want to thank our sponsors, Medela Auto Wipes and Prolacta Bioscience, for their ongoing support. And CPBF is a registered charity, and 100% of all donations received this week go to our support programs for families. To donate, please go to CanadianPremies.org. Together, we can create a brighter future to all premature babies and their families. And tomorrow we'll be back with Diana Schultz talking about kangaroo care. The next week is a kangaroo care day. So you're going to start this conversation tomorrow. And I will also have Misty Williams joining us from US, discussing evidence-based neonatal skincare practices. So thank you so much for watching, and I hope we'll see you tomorrow. Thank you. Stay well.